neurology examination. Examination and neurology, like examination of any other system, we should start by the fixed thing the beginning of every examination by introduce yourself and your role and take permission and do antiseptic. And then I check the position, privacy, and make exposure, and check the light. And then you should look to the surrounding besides the patient. Here in neurology, in respiratory, maybe inhaler or nebulizer machine or other. Here in neurology, maybe walking aid besides the patient or wheelchair besides the patient. Sometimes also the shoes, there may be scuffing of the shoes from deformity in the foot. And all this comment about surrounding besides the patient of wheelchair or scuffing of the shoes or any walking aid or other, we should comment about it. Then you look to the surrounding within the patient. And this surrounding within the patient, sometimes patient, neurology patient may have intra-urethral catheter. Anything that is surrounding within the patient, we should comment like intra-urethral catheter if he has sphincteric disturbance. Like NG tube if he has bulbar palsy or swallowing problem. Like IV cannula if he is admitted to hospital and receive any IV medications. And also, you should comment to the general look after surrounding within the patient. We should comment to the general look of the patient if he is look ill or well, and if he is comfortable at rest or is on pain or distress or others. And also the body build, if he is cachexic, low body build, or moderate body build, which is average body build, normal, or high body build, obese. So you should comment about all that. And this like a beginning of every examination related to any other system. So again, you start by introduce yourself, your role, and take permission, and then do antiseptic check, derive position, light exposure of the patient, and look to the surrounding of any walking aid, wheelchair, or any scuffing of the shoes or others, and surrounding is the patient of any intra-urethral catheter, any NV feeding, and or any IV cannula, and then the general look of the patient is look ill or well and comfortable at rest or not, and the body build low, moderate, or high body. Then after that, you start the examination. Often the examination is starting by the lower limb. So you start examination by the lower limb. You should, here the exposure should be till the mid of femur. Exposure ideally should be till the mid of femur. You should communicate with the patient at any step of examination. هرفع لحد فوق لحد منتصف الخط. So you should communicate with the patient at any step of examination. So you expose ideally should be till the mid of femur. This gives you good looking for the muscle bulk in the femur for wasting, and also when you come to the reflex for the contraction of muscle as a response to reflex. So you do well exposure, and then you correct the position. After exposure, we should correct the position. To begin by the first step of inspection, after correction of the position, to put the both lower limb in anatomical position. Then you comment about the position. After you correct the position to anatomical position. So here is the position, there is a slight deviation of the right foot. And there is some contracture deformity in the right knee. A slight deviation to the right of the right foot, a slight lateral deviation of the right foot, and a slight contracture deformity in the right knee, as to compare it by the left side, by the left lower limb. So after that, after you comment about position and if any deformity is present, then you comment about wasting. So no obvious wasting. No obvious wasting. Then if any abnormal movement, you also comment about it. No any abnormal movement, then you comment about any fasciculation. So here no visible fasciculation, and this normally appears in the muscle bulk. Then you induce. So by heightening by the index and middle finger like that in area of muscle bulk to see for any induced fasciculation. So no induced fasciculation, and this appears as spontaneous contraction of the muscle, spontaneous contraction and relaxation of muscle. So no any spontaneous or induced fasciculation. So after that, you raise the lower limb to look for any scar of tendon release of acyl tendons. This is done sometimes if there is contracture or spasticity, so they can release the tendon of acyl tendons. So here by surgery. So here no any surgery or scar of tendon release and no bed sore. And also you comment about bed sore in the penis of the lower limb in the bony prominence. So no bed sore and no scar. No cervical scar and no bed sore. So after that you complete the inspection. You first after exposure correct the position to anatomical position as we did, and then here there is lateral deviation of the right foot. Then you comment about any deformity. There is contraction deformity in the right knee for any wasting, no wasting, no visible or induced fasciculation as we did, and no abnormal movements. Then you raise the lower limb to look for any cervical scar or bed sore. So no cervical scar or bed sore. Then after inspection, you start by tone, and the organization is tone. Is by you begin by tone, then power, reflex, then coordination, sensation. Tone, power, reflex, coordination, sensation. We should go by this organization. So you start by tone, and there is 3 maneuver for tone. There is rolling like that, and lifting like that, and then passive movement. Rolling and lifting normally just detect if any spasticity is present or not, and passive movement can be able to detect if there is hypertonia. So when you start, if you suspect that there is abnormal side and the other side is normal, like from inspection, you start by the normal and compare with abnormal. So you start here by this suspected to be normal, and better to start by rolling and lifting. So you'll start first by rolling and lifting, and you should ask the patient about pain and look to the face for any pain. You communicate with the patient at any step. في أي وجع؟ طيب لو في أي وجع وريني. So you start by rolling. And this done like that, you feel for any spasticity or any flaccidity. Spasticity in upper motor neuron, flaccidity in lower motor neuron. So here there is spasticity in the right lower limb. So as I compare this side with this side, I feel that there is a slight spasticity in the right lower limb. Then after that you do lifting. لو في أي وجع وريني حرف عريض. So here this is for lifting, and also give clue about any spasticity or flaccidity. So I feel that there is some spasticity in this right lower limb. If the lower limb is heavy, this means that it is spastic, it's come against gravity rapidly. And it can hide the bed rapidly. Not like the flaccid or it is normal, it come normal, but the flaccid, it comes slowly because of it will be not will be heavy, it will be thin, so it comes slowly, not like the heavy object. Again, is the gravity. So here, when you compare this suspected normal side to this abnormal side, you find here in lifting that this is look like normal. But here, when you come here, it is look like spastic. So here there is a spasticity in this side of the right lower limb. So you suspect that here there will be hypertonia, and this side suspected to be normal. So you will start passive movement after rolling and lifting. Then you will start passive movement and you compare every joint by joint. لو في أي وجع وريني. In every step you talk, communicate with the patient and look for the case for any pain, because sometimes this may cause pain. So I feel there is normal tone in this right left lower limb and hypertonia in the right lower limb in the hip joint, then the knee, and every joint by it is full range of movement. The hip rotation and the knee flexion, full flexion and extension. And always looking to the face for any pain and first ask the patient about any pain. So I feel also there is hypertonia in the right knee, and then you come here for the ankle also by rotation. And you compare with this side, also I feel hypertonia here in the right ankle. So here there is normal tone in the left lower limb and hypertonia in the right lower limb in the right hip, knee and ankle. Then after tone, rolling, lifting and passive movement, then you go to the power, because the organization tone, power, reflex, coordination, sensation. Then you go to the power. In the power, you start also compare the normal with abnormal like any other maneuver. So you start here by suspected normal side. تقدر ترفع رجلك دي فوق. You do first general screening for power. So this means that there is 3 plus and above. تمام. طيب ارفع دي برضه. So I suspect there is some weakness here in this right lower limb. There is some weakness in this right lower limb. خلاص نزيلها. But it is generally 3 plus and above. So you start to do power by muscle group, and you start firstly in the femur muscle, and you start power by the power by the muscle group. First you start by the side. Before you do resistance for the patient, say to the patient in the femur raise slightly or lower limb, because if you resist immediately before he raising slightly, he may be unable to raise it from the bed. So first you say to him raise it slightly from the bed. ارفع رجلك شويه كده من السرير. تمام. Then you say the patient resist me by your full power. طيب غاولني بأشد ما عندك. بأقصى ما عندك. So I see here there is weakness here in the right side, and the left side there is resistance. It is grade 5 in the left side for flexion. It is grade 5. And here for the flexion in the right, it is grade 3 plus. 3 plus. شديد. So after that you do for extension by the same way. نزل شديد غاوي. I see also here the left side is normal, grade 5, and here the right side is extension grade 4, more better than flexion. And this goes pyramidal shape weakness. Pyramidal shape weakness, the flexors in the lower limb will be more weak than extensor, and in the upper limb the extensor will be more weak than flexor. This is pyramidal shape weakness. This goes with upper motor neuron. So here the flexor is weaker than the extensor here. The extensor here is the female grade 4, but the flexor grade 3 plus. So after that you do abduction, and abduction in pyramidal shape weakness will be more weak than abduction. This opposite to the peripheral lower motor neuron lesion like muscle disease, where the abduction will be more weaker than abduction. And in proximal myopathy, the proximal muscle will be more weaker than the distal. And also opposite to peripheral neuropathy, where the distal part will be more weaker than the proximal. And so here I suspect pyramidal shape weakness. This goes upper motor neuron of flexor more weaker than extensor, and abductor more weaker than adductor. So I take the abduction. لازم رجلينك لبره شديد بأقصى ما عندك. So I see this side, left side normal, but the right side is grade 3 plus. When I come to abduction, داخل عليك لجوا شديد. I see the left side is normal grade 5, but the right side is grade 4. So abductor is stronger than abductor in the right side. The left side is normal, but in the right side, the abductor is more stronger, abductor more weak than abductor. Flexor weaker than extensor, and abductor weaker than adductor. In abductor, in the right side, which is grade 3 plus, but abductor is grade 4. So abductor is weaker than abductor, flexor weaker than extensor, and this go with pyramidal shape weakness. Then after that, I do for the leg by flexion and extension. Flexion and extension. And I should support, when I do extension, I should support in the penis of the lower femur. Penis the lower femur, I will support by the other hand. I do resistance by my right hand, and I say the patient push my hand to see the extension. Push my hand. So this يدي شديد بأقصى ما عندي. So this is the normal side. This normal power. Then I support here for the upper femur in the above or in the upper part of the lower femur, and I say to the patient superior part of the lower femur. Say to the patient flex, and here this is support by the left hand, and I say to the patient flex. يرى عليك شديد. So this is normal, grade 5. Then after that I come here to do the same thing. I support the upper part, I support the lower part of the lower part of penis in the inferior side, in the lower part of the femur in the inferior side, and I say to the patient push my hand also. So here extension grade 4. Then I see the flexion, and I suspect it will be grade 3 plus, because flexor should be weaker than extensor in pyramidal shape weakness. I support here is the upper part of the femur in the superior, in the upper part by my left hand, and then say to the patient flex. يرى عليك شديد. So it is 3 plus. 3 plus, not like the extensor. When I see extensor here, this is grade 4. By flexor here, you're عليه, this grade 3 plus. So this means that flexor weaker than extensor, or flexor in the lower limb are grade 3 plus and extensor grade 4. Abductor grade 3 plus in the right side and abductor grade 4. The left side is totally normal. Then I come to the foot. I support the lower of the leg, and then see the foot to resistance of the foot, and you should do for all direction. Dorsiflexion, plantiflexion, inversion. In both sides you compare the normal by abnormal side. طيب دوس لتحت شديد لفوق بجاي. So this is normal grade 5 in the left side. طيب دوس لتحت لفوق بجاي. So it is grade 3 plus here in the foot. Normally in the pyramidal shape weakness or upper motor neurons, the distal will be weaker than the proximal part. The distal, the muscle will be weaker than the proximal part. So that is why it is grade 3 plus here in the foot. Not like some extensors above is grade 4 and abductor above grade 4, but flexor and abductor in the right side are grade 3 plus. So after that, so here the weakness is more distal. So this all go with pyramidal shape weakness, upper motor neuron in the power. Generally the power grade 5 in the left side and grade 3 plus in the right side. But by power by the muscle group, it is grade 3 plus for flexor and for flexors, and also in distally in the foot, and it is grade 4 for extensor and abductor in the right side. So after that, so this goes pyramidal shape weakness, upper motor neuron. So after that, after power, I do reflex, and also start by the normal side and compare with abnormal side. I flex the foot and support. I flex the lower limb, the left side here, and I support my forearm, and I touch the tendon by both fingers here of the right hand. I touch the tendon, and then I take the hammer and I hold it by my right hand, and I support by forearm of my left hand in the beneath the knee of the patient in the flexion position, and I hide the hammer by my hand, not by my elbow, by wrist. I move by wrist, not from elbow, by wrist, and it will be not slight and not strong. It will be middle power and by wrist. After confirming the tendon here, after touching the tendon, then I holding the hammer and move by wrist, by middle power, and I see here the contraction of muscle for detection of the reflex. So I will do that. If it is not appear, you do reinforcement by saying to the patient, holding your fingers and pushing it together, or clench your teeth. So I say to the patient here, clench your teeth, because I see here in inspection that the right upper limb is weaker and has deformity. So I see to the patient, clench your teeth. عض سنونك شديد. So this is normal area. Normally the power will be hyporeflexic or areflexic. This is normal. In any normal person, the reflex should be in hyporeflexia or areflexia. Then after seeing that it is going with areflexia here in the knee, then we come here to the other side and I compare both side by side. I compare here for this side to see the reflex here. After again support by my forearm and touching the tendon and holding the hammer by wrist and move my middle power. So I see here there is hyperreflexia. So if it is appear for the first time, no need to repeat and no need to do reinforcement if it is appear that there is hyperreflexia for the first time. Then after that, so there is hyperreflexia here in the right knee. So after that I do for the ankle, I start also by normal. I make slight flexion for the knee and dorsiflexion, slight flexion for the knee and dorsiflexion for the ankle, and I put the the other limb above the mid leg of the other limb, and I will touch the tendon here, of a side tendon, and then I by the same way I hide the tendon. So if it is not appear, so this appear as contraction, reflex appear as contraction of muscle in the penis muscle of the or peroneal muscle here of the leg, and appear also sometimes as movement of the foot. This tongue can appear by reflex can appear by like that. So I hide like that. So if it is not appear, I do reinforcement at this moment. So this is go with normal reflex. Normal reflex. So this means that there is hyporeflexia in the hyporeflexia in the left side knee and ankle, and this is normal. Then I go to the abnormal side, also flex the knee here and also flex the ankle and put the foot in the above the mid leg of other side and take the tendon also, and then hide by the rest again by the same way. And look here for the contraction of muscle of movement of the foot. So this is go with hyperreflexia, appear as contraction here of peroneal muscle and also as movement of the foot. Again, we will repeat. So this go with hyperreflexia. So this is obvious. Again. So this go with hyperreflexia by movement of the foot and contraction of the muscle. So after that, so I confirm that there is hyperreflexia in the right side. Then you not complete the reflex by unless to do the plantar reflex for Babinski sign. So you do it by start by moving any subject, stick or other that has some sharp object but not so sharp to not injure the patient, and move it gently. You start from the medial side of the sole and move laterally until to reach the big toe, until to reach the tendon of the big toe, and see if there is upgoing. This is goes upper motor neuron, or downgoing or equivocal, and this can be in normal person or with lower motor neuron like the other reflex. So you start by normal side also and doing like that. حامل شخطة في رجلك. Yeah, as we said, you communicate with patient in every step, and I do like that the plantar reflex. So it is down going, and this is normal. This is normal. Then I do for the abnormal side here, and I suspect it may be upgoing because of the upper motor neuron and hyperreflexia. So you start by the same way I move. So it is upgoing. I see that it is upgoing here. So this means that it is positive plantar reflex, upgoing. When we repeat it again, so it is upgoing. So this means that it is positive plantar reflex. And this is the most common test that doing Babinski sign for the plantar reflex. There is other maneuver, there is some test there, shadow test there, Gordon test, but this is the most common way that is used, and this that is required for, especially for undergraduate, it is mandatory to be done. So there is upgoing TUI in the right side. So this means that it is upper motor neuron, hyperreflexia in knee and ankle, and upgoing TUI in the right side, and normal in the left side of hyperreflexia and downgoing TUI. So after that, after reflex, if there is hypertonia, you should do clonus before to go to other step. Here you complete the tone power reflex before to go to coordination and sensation and sensory examination. You should end the tone power reflex by clonus if there is hypertonia, and this side is normal. So no need to do clonus for it, but you do clonus, and if it is not normal, if hyperreflexia and downgoing, it is going with lower motor, no need to do. Only clonus is done for hypertonia. So you do clonus for the side that, because this side is normal, you do clonus here for this side that has hypertonia by slightly flex the knee. The maneuver is by slightly flex the knee and hold the knee by the other hand, and by right hand you make sudden repetitive dorsiflexion by right hand. This, if there is clonus, it appears. So there is positive clonus. There is positive clonus. And this go with severe hypertonia. There is positive clonus, and this go with severe hypertonia. Sometimes it may not be appear, but if you do sudden repetitive and slight flexion here in the knee, and sudden repetitive dorsiflexion by your right hand. So this is visible clonus. This indicates severe hypertonia. Severe hypertonia. So here there is positive clonus. So after you complete this examination and you see from the start by general in general looking that there is some deformity here in the right hand and suspected weakness here in the right lower limb. So this may go with hemiplegia or hemiparesis. So you suspect coordination and sensation that will be normal. You suspect that there is no affection for coordination or sensation in patient with hemiplegia or hemiparesis. It's not like other paraplegia or other. Better to postpone the coordination and sensory examination for the end and go to the upper limb and also doing inspection tombo reflex to confirm the hemiplegia. Then you go to the facial to confirm that there is crossed or uncrossed by the upper motor neuron facial palsy, and then you go to the cardiovascular examination because it is the most common risk factor for ischemic stroke. So I will postpone my coordination, cerebellar and sensory examination for the end of the examination, and I go to examine the upper limbs. So examination of the upper limbs, first you do exposure like the lower limb. هرفع هنا هفتح لك. You do exposure here till the mid of arms. You do exposure till the mid of arms. After you do full exposure, ideally till the mid of arm, and for the same reason, to see the reflex here by contraction of the muscle in the arm. And this for the same reason when you come to do reflex, and also to see wasting at the beginning of the examination in the area of muscle bulk in the humerus. So first you put the upper limb in anatomical position like that, and then you comment by inspection. So by inspection here, there is medial deviation. There is medial deviation of the right hand. There is medial deviation of the right hand, and also there is flexion deformity in the right hand, and also flexion deformity in the fingers in the right hand, and there is no obvious wasting. There is some scar, mostly from trauma or from cautery marks, mostly from trauma and cautery marks in the above the wrist of the right hand. And then you comment about any abnormal movement, no any abnormal movement. Then you comment about fasciculation, no visible fasciculation. Then I want to induce by heightening again in the muscle bulk, here in the upper part of the forearm, and here then in the upper part of the forearm in the other side, and then in the arm. So no visible or induced fasciculation. Then you rest also the both upper limb to look for any surgical scar or any bed sore. So no surgical scar or no bed sore. So here in the by inspection of both both upper limbs, there is after correction of the position to anatomical position, there is lateral medial deviation of the right hand, and also there is flexion deformity of the right wrist, and also of the right of the fingers of the right hand, and also there is some scars due to cautery marks in the right upper limb, and no obvious wasting and no abnormal movement. Then by raising and seeing is in the underside of both upper limbs, there is no scar and no bed sore, and also here there is no visible or induced fasciculation as we did in the muscle bulk in both sides. So after inspection, then you go to the same organization, tone, reflex, then coordination, sensation. So I start by tone, by the same way. So I compare, as we said, the normal with abnormal side. Here there is no rolling and no lifting, just passive movement, and we start by every joint by full range of movement, and you compare to other side. Also communicate this patient and look to the face for any pain. لو في أي وجع وريني. Then you compare here. Every joint by its full range of movement, shoulder by rotation. So I see here there is hypertonia in the right side. So then here, so there is hypertonia in the right side. Normal tone is the left side, and hypertonia is the shoulder, right shoulder, elbow, and wrist. So there is hypertonia in the right side and normal tone is the left. Then after that you do power by the same way. ارفع يدك فوق. تمام. طيب ارفع دي. And there is also the left side. You can do it as general screening of the power. تمام. So since there is here grade 5 in the left side and grade 3 plus in the right side. Then you do drift ارفع ايدينا كده drift side كده خدهم كده زي غمض عيونك. The abnormal side develop positive drift. It come down like that. It's not like that. This normal side it will come like that. So like this here. It is opposite to this, and this positive drift. It come down and opposite to this side. This positive drift side. It indicates that there is a weakness in this side. Indicate hemiplegia or hemiparesis. So خلاص تمام. So it's done by raising both upper limb out, stretch hand like that, and say to the patient, close your hand. The side that is hemiplegic will come down like that. So this indicates positive drift style. So then after that. دقيقة. طيب هتواصل. طيب then after that, after you comment about you comment about grip sign, as we said, you put your both upper limb like that, out stretch hand, you do upper limb out stretch it like that, and say to the patient, close your eyes. The size that is abnormal, one week will come like that down. This term is positive new sign. It indicates that hemiplegia in the side that is affected. So after that, you will do a power by muscle group by the same way. And here you put the both upper limb in 120 degree. You put both upper limb in 120 degree, and then you compare all sides, all direction of movement, abduction, and flexion and extension, all direction of movement, and every here this for both arms. You do this or for this side. So first you do abduction, this level. You see this side is normal, because this side is weak. This side is grade 5 and this side grade 3 plus. Then you go to the abduction. You're على Also, this side is normal, this side grade 4. Also, abductor is weaker than adductor, as this goes pyramidal shape weakness. And we expect both here extensor is weaker than flexor, opposite to the lower limb in pyramidal shape weakness or upper motor neuron. So again, this for abduction, you release the hook. This 3 plus here is the right side and normal is the left. You're على abduction here grade 4 and normal in the left also. So abductor grade 3 plus and abduction grade 4, then flexion and extension. This therefore. So it is 3 plus here. Here this therefore. It is grade 4 here for flexion and normal for the left side. Then for extension grade 3 plus in this side, in the right side, and normal in the left side. So here the flexion is grade 4, but extension grade 3 plus. This means that extensor weaker than flexor, and this goes pyramidal shape weakness. Then you go for the to compare the full flexion and extension in the elbow, and also you support by the left hand, and you compare both sides. You're عليك for flexion, then extension لسه برا. So this is normal grade 5. Then you come here to the weaker side, and also you support by the same way. You're عليك. So flexion grade 4. Flexion grade 4. طيب لسه برا. But extension grade 3 plus. So this means that extensor weaker than flexor. This goes by pyramidal shape weakness. Then you come to the also full direction of movement of the hand, and you expect the weakness will be more distally, like in the lower limb, in the upper motor neuron. So you support here, this is the normal side. Full direction of movement of the hand. So here it is more weaker than the upper. Even he cannot do anything. So it is grade 2 here. It is grade 2 here in the right upper limb. Even cannot move well. Just can move like that. It is grade 2 here. Then you do for the finger. This every finger by it is finger. Every corresponding finger, the right to the right, left to the left, and index to index, little finger to little finger. This Then you take the patient, hold my finger here for index, جرعة شديد. طيب جرعة هنا شديد. He cannot do that. So it is grade 2 here in the right side. Normal bore in the left hand, grade 4 for extensor in the right, and grade 3 plus for flexor, and grade 2 distally. And for adductor, grade 4 for adductor, and flexor grade 4 in the upper limb, but for extensor and abductor grade 3 plus, and distally it is grade 2. Then after bar, after tone and bar, then you do reflex by the same way. You put here in the 120 degree for biceps, and you start also by normal and compare with abnormal. You touch the tendon firstly by your finger, you touch the tendon, and here you do support by the finger. In biceps tendon, you do support by the finger, by the left hand, and you hide by the right hand by the same way, and you look for the contraction of muscle here in the arm or here in the forearm, sometime by movement of the forearm. So you start by normal sign and do it. If it is not appear, do reinforcement at the snooner. So here it is hyperreflexia, and this is normal. Then you come here to the abnormal side, and also you do the same thing. You touch the tendon, and then you put your middle finger of the left hand, and you help the hammer by the same way, and you do here for this side for biceps. So it is obvious that there is movement of the forearm and contraction of the muscle. So this indicates hyperreflexia in the right biceps. Contraction of the muscle, movement of the hand. So hyperreflexia in the right biceps. Then after that you do for brachioradialis by the same way. You put your middle finger in the brachioradialis of the left side by the same way, and you hold the hammer and you do by the same way. This appears as movement of the hand or contraction of the muscle here in the forearm. So if it is not appear at the sunak, so it is hyperreflexia, it is normal. Then you do here for this abnormal side by the same way. So this is appear here as contraction of the muscle, even movement of the forearm, and movement of the hand in this side. So this indicates hyperreflexia in the right side, also in the brachioradialis. And then you go for triceps, and you put here the upper limb in the 90 degree. In the 90 degree for triceps. Here no need to put the finger because here no bone to support. Just you hide by the, after touching the tendon, you hide by the hammer, and you see contraction of the muscle in the triceps muscle here. So this is the normal. If it is not appear, do reinforcement at the sunak, and then you do again. So this is normal. But here, when you do here, you touch the tendon, and also you do by the same way. So it is appear hyperreflexia by contraction of the tendon. After touching the tendon again by the same way. So it is appear hyperreflexia here by contraction of the muscle and movement of the upper limb, excessive contraction and movement of the upper limb. So there is normal reflex or hyperreflexia. This is normal in the right side, in the left side, and hyperreflexia in the right side, biceps, brachioradialis, and triceps. Then after reflex, then we postpone the coordination and sensory examination for the end. We can combine all of them together for both upper and lower limb. So after reflex here, after tombo reflex, you go to examine the facial to confirm that there is upper motor neuron facial that go with hemiparesis. If it is in the same side, it means that ankyros go with cortical lesion. If it is opposite facial to the side of limbs weakness, it means that crossed, and this go with brain stem lesion. So we see the facial. First you will inspect the face. Then after inspection, there is seems that there is some weakness here in the right lower part of the face. Then after inspection, you do for power. For power, first facial expression, say to the patient, smile, ابتسم. So you see that here the buccinator is moving well in the left side, but it is weaker, unable to move in the right side. Then after that, you do say to the patient, occlude your limbs together. Occlude your upper and lower limbs together, upper lips of the mouth together, and you resist it by both some of upper and the upper and lower side. You resist the patient. طيب ضم شفايفك عليك شديد وانا بقاومك بالدياني هنا. You start by normal and compare with abnormal. You see here the power. عض تاني شديد ضم شفايفك. You see that here it is weaker than here. تاني. تاني. You see that here in the right side is weaker than the left side for this for orbicularis oris, which is muscle also of the facial. And then after that you do the same thing by saying to the patient, close your upper eyelid and lower eyelid of the eye together and resist me also by pushing down and up by my both thumb of both sides. طيب you compare also the normal with abnormal. طيب ضم عيونك عليك شديد وغاومني. طيب تاني هنا. You see that here the lower eyelid is weaker. The lower eyelid is weaker in the right side. This goes affection of the lower part of the face in the right side because the upper part it should be is bent. So that is why upper eyelid is seen normal in both sides. So after that you say to the patient, do wrinkling of the face by elevating to respect the wrinkles muscle in frontal area by elevating both eyelashes up. So عين لفوق كده عامل قفة حواجبينك لفوق. So it is normal in both sides. There is appearance of exhibition of wrinkles muscle in the frontal area. So this is indicates that it is normal. It's the upper side. So this indicates that there is affection of the right lower part of the face. Indicates that right upper motor neuron palsy of the right facial nerve. Upper motor neuron palsy in the right facial nerve. So this appears as in smiling and in orbicularis oculi, in orbicularis oris and lower eyelid of orbicularis oculi muscle and intact the upper part of the face. So affection of the lower part of the face in the same side here. This means that it is anchorous and go with cortical lesion. Anchorous mebaris and go with cortical lesion. So there is affection of the upper motor neuron of the right facial nerve. So right upper motor neuron facial palsy. So this indicates that in the same side of lymph weakness, this go with right hemiplegia or hemiparesis, ipsilateral right upper motor neuron facial palsy. This go with anchorous hemiparesis. So this go with cortical lesion. So after examination of facial, you come to examine the cardiovascular. And cardiovascular, you feel here the pulse for any atrial fibrillation. If any irregular, this go is atrial fibrillation, and this one of the common causes of ischemic stroke. Then after that, you auscultate by stethoscope the carotid in both sides for any carotid fluid. This go with carotid thrombus. It is one also of the cause of the. It is one also of the causes of ischemic stroke. You auscultate by stethoscope. So the pulse here is regular. Then you auscultate by stethoscope for the carotid in both sides, and you auscultate by bell for any carotid fluid that is go with carotid thrombus. This one of the most common cause also of ischemic stroke. Then after that you auscultate the pericardium for any murmur that either may indicate mitral stenosis or aortic stenosis. This one of the cause also of paradoxical impulse or due to infective endocarditis that affect any also mitral or aortic valve as mitral aortic stenosis. You auscultate for any valvular area, and you concentrate more in the mitral and aortic for mitral or aortic stenosis. Also, sometimes if patient do a bursitic valve, this also risk factor for risk factor for thrombus because the mechanical valve has increased tendency for thrombus. So you auscultate for any murmur, so no murmur. So there is normal rhythm of the pulse and no carotid fluid and no murmur. So after that you come to complete your examination. You postpone the coordination and sensory examination for the end. So now we come to complete the examination by coordination and sensory examination. You can combine both together. So by coordination, so you do coordination and then sensory examination, and you do here in the lower limb by shift chin to shaft. You move here the penis side of the foot to in the other side. It is termed chin to shaft test, and you do it here. طيب هتمرر you do learning first to the patient, and you do by the normal side. هتمرر الكعب من الركبة لتحت هي، وتاني ترفع لفوق المررة من الركبة لتحت. From knee to ankle, and then elevate it again, and also move the lower limb from the knee to the ankle. Then you compare. It is done just twice. يلا اعمل دي نفس الحركة دي هنا. It is done twice. If it is unintact, you see that there is dysmetria, unable to reach the target with intention tremor that appear in the twist. So there is normal tune to have this. Then after that, finger to nose test in the upper limb by the same way. خد صباعك هنا في نفرتك وجيبه في صباعي كم مرة تاني. It is do within the arm reach of the patient. Then you do by this way. دي تقدر. It may be unable because of the weakness. Also, you see the dysmetria and intention tremor in the finger. So there is intact finger to nose test. Then there is this diapokinesis done like that. If finger to nose and tooth to shaft test is intact, no need to do this diapokinesis and other tests because you will not examine here for cerebellar. This just to complete the examination for coordination. So here there is intact coordination in both lower and upper limb. Then after that, you do the sensory examination and also you combine the both sides. Normally you do by needle sting here for beam this for lateral spinothalamic tract for pain. And you should be specific, not just say to the patient feel or not feel. You should say do you feel pain or not, because you know pain and temperature by lateral spinothalamic tract, growth touch by anterior spinothalamic tract, fine touch and proprioception by vibration and position by dorsal column tract. So sometimes patient may feel by touch, not by pain. So you should be specific for empiric, this pain. And also for vibration, sometimes may feel by touch, which is be specific this vibration, if you feel or not. And say to the patient 3 options. If you feel like that or less or not feel, tell me. Sometimes may feel less, but so feel but less. So if you feel like that or less or not feel, tell me. So you start by empiric for lateral spinothalamic tract. طيب الطعنة دي حاسبها. طيب وريني تحت يو هايت in the frontal area and then you compare here. وريني تحت هنا في رجلينك وفي يدينك. لو حاسس زي وريني عقل، لو وريني ما حاسس وريني. You start here dermatomery here. هنا حاسس زي الفوق. هنا زي الفوق. You start dermatomery هنا زي الفوق. هنا زي الفوق. If intact distally, no need to proceed. Then you go to the upper limb also. هنا زي الفوق. This here for radial. Then for the palmar side, for hypociner, for ulnar, in the dorsal for radian, but in the palmar side for cinar, for median, and hypociner for ulnar. Then هنا زي الفوق. You compare for both sides زي الفوق. This for cinar, then hypociner زي الفوق. Then هنا زي الفوق. So here the empiric sensation is intact. Then you go to the vibration. If it's intact distally, no, you will not proceed. So you go to the vibration. Vibration, you hide the both slits of the hammer by your border of the left hand, and you hold here in the lower knot to touch the lids here, because if you touch it, the vibration will be absent. So you hold here from the lower side and you hide by the border of the other hand like that, and then you put here in the frontal area. حاسب الهزاز ده. You say to the patient if feel like this vibration or less or not feel, tell me. لو حاسس زي تحت ورينا، قال له وريني ما حاسس وريني. You start in the bony prominence. First in the base of the malleolus, medial malleolus, or first in the metatarsophalangeal joint of the big toe, then in the medial malleolus. So you start here also. If intact distally, not proceed proximal. So you start here. حاسبه زي الفوق الهزاز ده. هنا زي الفوق. Then if intact distally, you will not proceed proximally. Then you go here for the upper limb. Here for also base of the thumb. Here زي الفوق. هنا زي الفوق for metacarpophalangeal joint. Then here you can do here for the base here زي الفوق. Also metacarpophalangeal joint for the distal زي الفوق. تمام. If it intact, so you will not proceed. Then you go for position. After empiric vibrations, then you go for position and you held here the base of the distal interphalangeal joint, base of the distal interphalangeal, not of the metatarsophalangeal joint, base of the distal interphalangeal joint, and you learn the patient first دي تحت ودي فوق، تحت فوق. تمام؟ غمض عيونك. دي وين؟ هنا. هنا. You ask the patient if it is down or up, if he is able to detect position or not. دي وين؟ هنا هنا هنا. So it is intact. After you holding the base of the distal interphalangeal joint and you ask the patient if it for down or up, so it is intact. So position is intact. So coordination and sensory examination for empiric position, empiric vibration position are all intact. Then after that you do gait. طيب خلاص تعال نازل نمشي. You do gate. And you see the gate here, there is will be circumductive gate. This goes من نيجا ده شبشبك. طيب تعال البس الشبشب. خلاص امشي تعال. So this goes circumductive gate. خلاص تعال. So this goes circumductive gate. So this goes circumductive gate. خلاص 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 الكيو تعال خلاص. This goes circumductive gate. خلاص خلاص خليه. طيب then after we complete the examination by examining the gate, then you mention that you comment that about you want to examine other. You want to examine the higher function, the higher functions. You want to examine the minimental state for memory. You want to do ophthalmoscopy for eyes. Fundoscopy or ophthalmoscopy for eyes, and you want to examine other cranial nerve, other than facial. You want to examine hypoglossal and all other cranial nerve. You do gag reflex for glossopharyngeal. You do for hearing, for vestibulocochlear. So you examine other cranial nerve. You examine higher function, mental state for memory, and then you do ophthalmoscopy for any optic atrophy or other for eyes. So this is just you mentioned it complete examination. Like in abdomen to do BR and inspect genitalia, this here to complete examination. Then after that you mention the summary. After you do all that, you do the summary. And in summary, you mention just the positive things that you find in all examinations, the positive thing. So in summary here, by examining both lower and upper limb, I find that there is in summary, by examining both upper and lower limb and facial and all other part of examination. By summary, there is by inspection of both upper and lower limbs, there is lateral deviation of the right foot and medial deviation of the right hand, and there is extensor deformity in the right foot and flexion deformity in the right hand, and there is some scars in the upper limb, in the lower and upper part of the forearm, and there is no any other. There is also contraction deformity in the right knee. There is extensor deformity, lateral deviation of the left, lateral deviation of the right foot, and the medial deviation of the right hand by position, and then there is extensor deformity and flexion deformity, extensor deformity in the right ankle, flexion deformity in the right knee, and there is flexion deformity in the right hand. And there is no, there is some scar in the lower side of the right forearm and upper side, also some scar due to Scotta remarks. So there is no other thing in inspection. Then by examining the tone, there is hypertonia. There is spasticity and hypertonia in both right lower and upper limb. And this combined with positive colonus. This combined with positive colonus in the right lower limb, combined with positive colonus. And combined also with hyperreflexia in both right upper and lower limb. And also with positive plantar reflexes upgoing to in the right foot. And also the power is in pyramidal shape weakness. This means that the flexor in the lower limb is weaker than extensor, and abductor in the lower limb weaker than abductor, and the weakness is more distally in the foot. And in the upper limb, the extensor weaker than flexor, and abductor weaker than abductor, and the weakness also is more distally in the right hand. As we see, the cerebellus in the flexor in the lower limb and abductor, and upper limb abductor and extensor cerebellus, but for in the others, abductor and in both upper and lower limb, and flexor in the and extensor in the lower limb and flexor in the upper limb. And then by examining after the power going with pyramidal shape weakness upper motor neuron, then by examining the face. There is right upper motor neuron facial pulsing. So after that, I examine the coordination and sensation for being vibration and position, and all are intact. When we examining the gate, there is circumductive gate. So my clinical diagnosis is go with anchorous hemiparesis. Anchorous hemiparesis because hemiplegia power grade 0. So my if power above 0 is not mentioned hemiplegia. So my clinical diagnosis is anchorous hemiparesis. So this indicates cortical lesion. So differential diagnosis, the examiner asks you differential diagnosis of clinical diagnosis. Differential diagnosis is causes of this hemiparesis. What are the causes? So you put the ischemic stroke as number 1 cause. The ischemic stroke as number 1 cause. Then after you put ischemic stroke, so you mention vascular ischemic stroke number 1. Then you mention maybe hemorrhagic stroke also. Then space occupying lesion like brain abscess, benign tumor, meningioma, glioma, or malignant tumor metastasis from anywhere. Then infection like both meningitis or encephalitis or other. So this all put in the differential diagnosis. Then the investigation. Investigation you can do immediate CT brain. To look to exclude hemorrhage and to look for any other cause, you do immediate CT brain plus or minus MRI. Sometimes I need to do MRI brain. Then investigation according to the cause. If you suspect ischemic stroke, then you do investigation for ischemic stroke. You do ECG, fasting blood sugar, fasting lipid profile, ECG, and carotid Doppler ultrasound and echocardiography. This for thrombus risk factor, cardiac and carotid thrombus risk factor for ischemic stroke. Then, if hemorrhagic stroke, you do bleeding profile and dilated count, bleeding profile and other, and clotting time and clotting count and prothrombin time and other. If you suspect hemorrhagic stroke, for example. Then after that, you go to the management. Management, you need multidisciplinary team, neurologist, physiotherapist. Patient need physiotherapy. Patient may need walking aid, occupational therapy. Sometimes patient unable to do function in the house or in his home, so need occupational therapy, some devices that can help him to do the function in his house, like opening the door or others. So physiotherapy, occupation neurologist, physiotherapist, occupational therapy, and patient need regular exercise, also need exercise and rehabilitation for his disability. Rehabilitation for his disability. Then the patient, if he is completely immobile, may need anticoagulant to prevent the thrombus formation, and need air bed matrix and other to prevent the bed sore if he is completely immobile. Also he may need care for bowel, urinary bladder by intravenous tester, swallowing by NG tube if he is in severe disability. If he is in severe disability, then the management is for ischemic stroke. Then a management according to the cause. After this multidisciplinary team, also patient needs social therapy, psychotherapy, and other. After this multidisciplinary team, management according to the cause. If it is ischemic stroke, the management will be of antiplatelet, of clopidogrel is first line, clopidogrel, and atorvastatin, which is anti-lipid. Then, in addition to modification of the risk factor, if patient hypertensive, diabetic, or other, you need to control all that. So that is all.